Our next speaker is Odette Gibson. I'll let you put the microphone on. And Odette's from SAMHRI, and she'll be talking on a type 2 diabetes strategy for Aboriginal and Torres Strait Islander people in South Australia. Thank you very much.
Okay, thank you. Is that working? Yep. Okay, great. Thank you, and thank you for this opportunity to talk about the development of a type 2 diabetes strategy for Aboriginal and Torres Strait Islander people in South Australia. Firstly, I'd like to acknowledge that we're meeting on Kaurna land today, and that, as Janet, the diabetes prevalence rate is several times higher in the Indigenous community compared to the non-Indigenous community. And based on the recent National Aboriginal and Torres Strait Islander Health Strategy results, the ABS estimates the diabetes prevalence rate in South Australia to be 8.9% among Aboriginal people and 4.4% among non-Aboriginal people. Diabetes generally presents in older age. However, Aboriginal people experience diabetes at a younger age. Diabetes alone explains 19% of the mortality gap between Aboriginal and non-Aboriginal people. We know that primary care service use by Aboriginal people is low, considering their high burden of disease, and that the rate of hospitalisations for diabetes and associated health complications is much higher in the Aboriginal population. What we do know is that diabetes is a big concern for the Aboriginal population. The incidence of diabetes is increasing, and we're now starting to see type 2 diabetes in young children and adults, very young adults. We also know how to manage diabetes well based on rigorous research and scientific evidence. We know that if we manage diabetes well, we can slow and even prevent disease progression to other complications or associated complications. We know that Aboriginal people aren't accessing primary healthcare services to their level of need. In our discussions with the Aboriginal community or Aboriginal people and service providers, we know that there is a limited understanding of type 2 diabetes, how it happens to people, how to manage diabetes, and what the consequences of diabetes are in the Aboriginal population. We also know across and within services, and these are government and non-government services, that there are multiple information systems that don't always talk to each other that are used to manage diabetes care. We know that there are multiple providers across services. It is a condition that requires many disciplines to manage people's care well. We know that there are multiple services available for diabetes and associated complications such as cardiovascular disease, mental health, eye health, and renal care. However, there are still many unknowns, and there is room for improvement. What we don't know is why Aboriginal people get diabetes at such a young age, and we don't know why some people go on to have severe and or rapid complications from diabetes. We don't know the healthcare system responses that manage diabetes effectively, and we also don't understand why Aboriginal people don't access services or use diabetes services to the level that they could be. We don't understand all of the reasons for that, and particularly given when we're talking about multiple providers, which is what Janet describes so well with the mapping tools. We're also not clear about the Aboriginal community's understanding of diabetes and also what the systems of responses would be or could be to improve care and outcomes. In establishing the Wadley-Paringa Aboriginal Research Unit, which is led by Professor Alex Brown at the South Australian Health and Medical Research Institute, during our initial consultations with the Aboriginal community and organisations, type 2 diabetes was identified as a community priority. In response to this, Wadley-Paringa has developed a diabetes program of research, and it focuses on translating our research findings into policy and practice, understanding the causes and preventing the consequences of diabetes, raising community awareness, and improving ways in which the health services can better manage diabetes. The scientific research that we're referring to as the Aboriginal Diabetes Study will endeavour to understand why Aboriginal people get diabetes at a young age and how to prevent the consequences of diabetes, and being able to predict cardiovascular, eye and renal events based on biomedical and genetic markers. The development of a diabetes strategy for Aboriginal people in South Australia is supported by the Aboriginal Community Control Health Sector, and it's also supported by and funded by SA Health. The development of the strategy will be guided by the National Diabetes Strategy for Action. The last diabetes strategy for Aboriginal people in South Australia was in 2000. So an obvious aim of this strategy is to improve the quality of life and increase life expectancy of Aboriginal people with diabetes. To do this, we need to understand the current status of service responses for managing pre-diabetes, the early detection of diabetes, the quality of diabetes care, the relationship between diabetes and social determinants of health. The strategy development will be governed by a diabetes steering committee, which will comprise of key service providers, multidisciplines and community advocates. We will work with 10 community control health organisations and 5 community control health organisations and 5 SA Health primary care services to understand the quality of care that's currently being delivered within these services, to understand and create a health profile of Aboriginal people with type 2 diabetes, and we'll also look at the primary healthcare system characteristics that are currently within and across these services to better understand those. There will be a mapping activity of all the available diabetes and related services across the state as well. During this time, we also will take opportunities to have high-level input from key stakeholders over the year-long development of the strategy. So all of this information will inform the development of that strategy, and during this process we hope to better understand some of the unknowns, particularly around the system responses to diabetes, and to be able to identify the Aboriginal community's needs with regards to their service and educational requirements.
Not just yet, we have time
Sorry.
for questions. Oh, we really have, yes. Okay, we have got time for questions, so maybe I can ask John to come and join you in case there are any questions that, because I know people had their hands up. Yes, so would you mind if you shared the mic?
Absolutely not. I'm happy to get up.
No,
Stay here.
Hi, it's Alan Cena from Women's and Children's. Question for John. You showed a slide where it would be £500,000 to save one death, is that right?
Yeah, well,
Yeah.
$500,000.
$500,000.
Roughly translation.
Sure.
Yeah.
Now, with every death, there's usually 10 major morbidities, usually associated within the system. So if you look at it in terms of another 10 morbidities per death, 10 divided by 500 per 1,000 would be 50,000 per extra morbidity as well that you would save. Now, healthcare for an extra morbidity would be way usually in excess of £50,000. Can I just have your comments on that?
Yeah, I wasn't making a decision or a judgment that it was good or bad value for money. I was just raising the issue that these improvements aren't costless, and that that's what I mean. If we evaluate it and we find that that's what it's costing, or that's what we're achieving in terms of benefits, then it informs decisions whether to go further or to stop. Or to
What I'm suggesting is it doesn't only cost money, it actually saves money, because by actually saving morbidity, the health service is actually saving maybe £100,000 in healthcare from a major morbidity that's saved. So you could be, rather than arguing that each death saved was $500,000 cost, we could in fact be saving $50,000 per death saved.
Yeah, could be. Yeah.
Can I ask a question, John?
Yep.
Given that we're looking at patient-centred care, so the patient has some decision-making to do as to whether they want that care or not that care or whatever, how does that affect cost-effectiveness?
So patient preferences for,
Yes,
for
opportunity,
care.
yeah.
Yeah. Well, I guess the honest answer is that it is not reflected well in the types of analyses that we currently do, because we tend to focus on objective measures of outcome, and that's an area that needs to be improved in terms of reflecting processes of care as well as outcomes of care.
Mm-hmm.
Yeah.
Thank you. That's
Kushila Kumar from Flinders University. Just to add on to Ellen's question, so you've talked about outcomes and you've talked about looking at processes, and I guess what I'm saying, what I'm thinking in terms of evaluation is we also need to ask how and why things change or why they improve or don't. So, how do you suggest we start looking at the context in which care is provided and sort of the mechanisms that might actually have an impact on why things happen or why they don't, and what those unintended consequences are? Are there ways of capturing that in your framework?
Well, as I kind of alluded to, I kind of gave myself a get out clause at the end. But the methods that I was kind of talking about are really, I kind of describe them as a screening tool. That is a quantitative analysis. You've got to recognise the limitations of those types of analyses, and so it's really identifying or trying to identify those areas that we need to do more detailed work, such as the mapping, because we can't, as Janet also said, we can't do the mapping as a general framework. You've got to pick and choose where you do that kind of more detailed analysis, and so it's really, I think it's a good example of mixed methods, that you use the quantitative to identify the areas that you dig deeper, and use those more qualitative aspects.
I have one for Odette. Odette, just
Can
thinking
you
about...
identify yourself, Carol?
Sorry, I'm Carol Davey from SAMHRI. I actually work with Odette, but I haven't had a chance to ask this question yet.
Gracious of you to ask me a question.
I'm interested to know, given the fact that one of the things you highlighted was we don't understand why Aboriginal and Torres Strait Islander people don't always access care, and I agree with that. Is there an opportunity to work with a mapping tool and mapping some of the journeys to see where perhaps sometimes they do break down, and find out why that might be the case?
Absolutely. Yeah, I think it's important because we don't know all the answers, and one of the things that I'm actually from Queensland, so from Queensland Health, but one of the things we don't know is that I'm starting to realise in South Australia is the complexity with regards to people in the country. And it's very, very similar to what goes on in Cape York and the Torres Strait, with multiple service providers, multiple opportunities for issues to occur along the way. And yeah, this is becoming evident, so I think it would be really valuable. Have you actually done any mapping around a diabetes care journey?
Not specific, but we can next week.
That would be brilliant. Let's do it. Yeah, I think it'd be important. Yeah.
Okay, and the last question.
Thank you. Chris Christensen from Cancer Voices. Jonathan, I was just wondering, variation is normal. I'm just wondering who decides what variation is acceptable in terms of transforming health, and who defines the quality and what we're benchmarking against.
So that'd be a question for Dorothy, wouldn't it?
Thanks, Dorothy.
Thanks. We're using peer data and benchmarking ourselves against the rest of the country, and similar sorts of hospitals and similar sorts of services, and the international peer-reviewed literature. So that's what decides what's acceptable, and I think that's a pretty reasonable approach.
Okay. Thanks very much, Dorothy. And can we thank all our speakers so far?